There's so much more to evaluation and management than just how to score a level. There's things like prolonged care, critical care. Today, I wanted to go over some of those more unique situations in evaluation and management, not just how to score an office visit. So, I will link the notes that I'm going to be using for today's video in the video description so you can follow along. It's a lot easier for you to read them versus having me read them to you. And also, then you can mark and print them out and stuff if you want to. Again, they're linked in the video description. By the way, I am Victoria. I'm a medical coder, auditor, educator, and content creator. And on my channel, I provide tips, tricks, and tutorials to help you be successful in the medical coding career. If you haven't already, I highly encourage you to subscribe and hit that notification bell so that you can get alerts when I post new episodes. So, let's get into some of these E&M coding cases. I thought today, since we're pushing more with all the advances in technology to ebooks and different online tools, that we will do this online today versus through the paper books. But definitely let me know in the comments what your thoughts are, if you like it when I go through the paper books or if you're okay with me going through the ebooks and digital tools. So, if we look at this first case and we read through, this is a patient that is in critical care. So, critical care services don't just mean the patients in the intensive care unit. Oftentimes, when patients are in the ICU, we do bill critical care, but not always. It's to provide direct delivery of a patient that is critically ill or injured. It's when they have vital organ systems that are at a high risk of deteriorating. There's complex medical decision making. The provider has to support different vital function systems. It's like life or limb problems, like organ failure. We're preventing the patient from crashing and deteriorating. It could be provided in the ICU. And we do have different codes for adult critical care patients versus pediatric versus neonate critical cares. Now, this patient example that we're looking at is one where it is an adult patient. There are certain services that are included in the billing of critical care, so we don't bill them out separately, and that there's different guidelines depending on the age again, but for the most part, it's things like interpretation of tests, chest x rays, vent management, vascular access. Those are included in critical care. So, what we're really looking for are things like the patient is deteriorating. We're looking for why these critical care services were met. We're looking for loss of an organ function. They're going to lose a kidney or a liver, or God forbid, their heart, or maybe even something like a limb, which may affect their ability to ambulate. So, for this case here, I highlighted a couple of things. So, this patient has an acute pulmonary embolism and acute renal failure. We have the total critical care time. Now, total critical care time, again, that has to be that the provider was exclusively treating that patient. They weren't uh, looking at other patient notes, treating other patients. They have on here the documentation is really good for this one. So, due to a high probability of clinically significant life threatening deterioration, patient required a lot of intervention. The provider had exclusive time that was separate from any of the other billable services when they were not treating other patients at that time. So we're looking at 120 minutes of critical care time. And again, you want to make sure that when you're looking at this in the CPT book, that you're reading through some of these guidelines, making sure that it meets the critical care criteria and that you're in the right age group. So for these adult patients, we have critical care 99291 is for the first 30 to 74 minutes. If it doesn't hit at least 30 minutes, it doesn't count as critical care. We would just code it to whatever the E&M code is for that location. 99292 is for each additional 30 minutes. Now, the nice thing here is that you don't have to do the math. Um, Basically, it is done for you in the CPT manual by the AMA. So 120 minutes would fall in this time range, the 105 to 134. So 99291 for one unit and 99292 for two units. And that is what we would bill for these services, 99291 times one and 99292 times two. Now, when we go ahead and look at this next patient here, Our next patient was an emergency department visit. Okay. So this is a patient who came in. This is a more straightforward example, I would say. Patient came in, they had a staple lodged in their left hand. Now, there was a procedure done on this patient, right? We removed that staple. When, however, we look at the descriptions of the removal of foreign bodies from like skin or subcutaneous tissue, it says that there has to be an incision and removal of foreign body. And if we look at this documentation, there's not really anything here saying that there was an incision. In fact, it says the wound was left to heal by secondary intention after it was basically pulled out. They just pulled the staple. Secondary intention healing is when they just leave it open. They don't do sutures or tape it shut in any way. It is just left open to heal. Which, because this was just a staple, that probably wasn't significant enough to warrant anything more than just cleaning and bandaging it, which is what they did. They did also perform an X-ray. So the X-ray was performed, and they reviewed the X-ray. We do not have time on here, and we wouldn't need time on here because emergency department visits are not ever coded based off of time. They have an unusual criteria where, because time in the emergency department can be so incredibly fragmented, where it's like, oh, the provider is doing 10 minutes here and 5 minutes here and over here, and kind of maybe treating different patients kind of at the same time. It's would be way too cumbersome for them to even keep track of time, so they are now just scored based off of medical decision making alone. So when we look at this, we can see here, we've got some medical decision making components. I want to use the AAPC calculator that is in Codify. AAPC's been pushing Codify a lot. I know some of their student packages that they're selling have Codify included in them. And again, as we advance a lot with things, it's good to get used to some of these digital tools. So we're going to start here. If you're wondering if you have Codify and you don't know how to use this tool, it is here under the coding tools. This is the E&M calculator 2023. So we're going to select our type of service. This is an emergency department visit. And it was when they say new or established, there is no differentiation between codes for emergency department or anywhere in the hospital of new or established. That concept applies in the office. So when they say new or established, it's kind of like new or established doesn't matter. Both of those are included in that. Or other emergency department services. So this falls into a patient who's new or they are established, one or the other. We'll just kind of pick a mock data service here. And this button is kind of confusing because there's not a yes, no, there's just the radio button. So the radio button effectively means yes. And the question is, was this an encounter that fits a description of an emergency department visit that does not require the presence of a physician or other qualified healthcare provider and therefore cannot be measured by time or medical decision making, such as a nurse visit? No. So we're not going to click that button. We are going to hit save. This is probably a good time to remind everyone that if you think I am talking too fast for you, in the very bottom of YouTube, you can slow down the settings a little bit so I'm talking to your personal speed preferences. So now we're over here to our medical decision making components. First is our problems. How many problems does this patient have? Well, when we look at the case, there's not even chronic conditions addressed here. They really are here for this staple lodged in their left hand. They might have some chronic conditions, but they're certainly not in the documentation that we've got. Small puncture wound, base of the thumb, a little bit of bleeding. Again, we did an x-ray. Wound was left to heal. So really, I would say this is an uncomplicated illness or injury. I don't see that there was the tendon involvement, bone involvement. It didn't affect any other sort of systems. It's going to heal up without a lot of intervention. So I would say this is an acute, uncomplicated injury. Now, next, we're going to go down to our data. So we did review that test result, that x-ray. We get credit for either the order or the review. So even if we saw, the order was placed for the x-ray, they're not going to get a credit for an order and a review. They get credit for one or the other. There was no documentation here for um, independent historian discussions, independent interpretation of tests with another provider, discussion or management. Um, Nothing was really there that meets any of these criteria here. It's a pretty straightforward one. If we did, it would, kind of come up with our totals down here. And here we just have the one. Now, when we get to our risk of complications, we do have in this note that the patient was given prescription antibiotics. They do also say that they had pain management or pain medication here, but it doesn't say what pain medication. So we don't know if that was Tylenol. We don't know if that was 400 milligrams of ibuprofen, a prescription strength of ibuprofen. We don't know. So, but we have antibiotics. So we're going to give the prescription for antibiotics. And everything else says just keep it dry, look out for infection, follow up with your PCP or a hand specialist. Now, this does say about suture removal, but again, it says here secondary intention. So there isn't really any sutures to remove. It might just be like a blanket template that they put in there, perhaps. So when all is said and done, if we scroll to the very bottom, it's going to calculate the E&M for us based off of it having low complexity, 99283. And each of these, I think it does kind of give us this is moderate. It tells us the total of data. And here, I don't know if it tells us what the level is, it looks like. No. But it also does say at the very top what the code is as well. So you can calculate it there. And of course, time based coding and then final code level. So now we'll get into our last note. This one here, I highlighted as a Medicare patient. Now, when you see that in your CPC exam, that's a red flag to go, oh gosh, they may be trying to test me to see if I know that there's a difference between the Medicare versus non-Medicare patients because Medicare oftentimes uses these G codes for things like OBGYN exams or their annual wellness visits or certain vaccine administrations like flu and pneumo. So that's something to pay attention to. Is there a different code you need to use because this is a Medicare patient? So this patient had a lot of issues. And because this was a long patient, if we look here at the very end, the provider just documented the time. And they have here this was a time spent with the patient, including eval, personal discussions with the family to obtain history, coordinate care. They talk about what they were doing this whole time, and it was 105 minutes. Now, again, this is prolonged care, because this is going to go beyond the inpatient admit. This was an inpatient admit. It says, boop, 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 patient will be admitted to the hospital. So this was an admit code. And the time for the admit code is 75 minutes. We are billing for 105 minutes. So when we see something that's more than the max for that code, we have to look at our prolonged services. Let me just bring up my CPT book for you. So here's our prolonged service codes, and we have different ones for if there was face to face care, if there's non face to face care, where the patient was located. And here we have them for our prolonged inpatient and observation patients. So if you'll note here, this is highlighted in green in mine, and that's because I wrote myself a little note. And this note says CGO316 for Medicare, which means I don't want to be in my CPT book. I want to be in my HCPCS. So let's go back here into my HCPCS book. And here is my HCPCS level 2 book. We'll open it up. And we're going to go to our G codes and we're looking for GO316. So I'm just going to scroll down. You could also do a control F, GO316. And here it is. Now, there were some changes made to this GO316. Originally, when we looked at what was provided by CMS, it was you have to meet the time threshold, pass it by another 15 minutes, and then when you pass another 15 minutes, that's when you can use this code. But there's actually some changes made to that. So here's what's written in the Federal Register, and I should do a whole other video on what's in the Federal Register. But you can kind of see here it says that for GO316, there was this correction made. It had previously said um, something, and now the GO316 essentially is billable when we've hit 105 minutes. So the total time for 99223, which is the highest level of inpatient admit, is 75 minutes. So how do we know like what to bill beyond that? Let me draw a little illustration because I think the illustration kind of helps understand a bit better. So when we're billing based off of time and we're doing prolonged care, we have to meet the highest threshold of that level for that service. So for inpatient admits, it's 99223, and this is 75 minutes, right? So now we need to bill an extra 15 minutes, and that gets billed with the G code. Now we're at 90 minutes. How many minutes did we have documented here? If we take a look at this case, it was 105 minutes. So at that point, we're at 90, so we can bill another 15. It has to be a whole unit of 15 in order to bill it. So we're at 90 with the 75 and 15, and then 105. So here is 90, here is 105. So for that total 105, we're going to bill the 99223, and we're going to bill G 0316 times 2, and that will calculate out to the total 105 minutes. So I hope you enjoyed these cases. If you did, definitely let me know in the comments below. I will see you guys in the next video, and until then, just keep on coding on.